Welcome all. This is DrMobeen from DrBeen.com. Today is an open forum. Today I'm going to go over some of your questions. So welcome everyone. Today is our heart-to-heart. So let's start. So I have some of the questions that are already here that were asked on Twitter and on YouTube. So I'm going to start with those questions, and then we will look at the questions here in the stream as well. And a request to you that if you have a question, please write with the question something like question, so that I can sift through the comments and see the questions. So let's start. So some of the questions that are here, I had tweeted a few days ago that we will have the open forum on this Friday. So here are the questions. Let's start. Let's get right into it. So Avok says, if I work hard and have developed habits to avoid getting the virus, if I do come down with COVID cold symptoms, what are the odds it's not the virus? 50-50. What else is going around and is very contagious? I ask because the odds I have it when the doctor help quickly. Put another way, I'll ask myself, how the hell did I catch a cold? I won't want to assume it's cold unless it makes some medical sense. So Avok's very good question. And this question has been asked many, many times before as well. I had done a discussion, if you look at the videos that I've done, in the early videos for the coronavirus, I had talked about the differences between and similarities between common cold and COVID-19. So the short of the answer is that just from the symptoms, one cannot say with certainty that this is common cold or this is COVID-19. However, in normal way, if you look at how WHO says this, is that a suspected case is someone who is either living in the area of the outbreak or someone who has been in contact with a confirmed case. These folks, when they develop symptoms, then the first suspicion should go towards COVID-19. Otherwise, generally, if you are not in an area of the outbreak, or you have not come in contact with someone who is COVID-19 positive, confirmed, then generally you are not a suspected case. But now here is Mobeen's opinion. I think nowadays the COVID-19 has become so prevalent that anyone who develops these symptoms of cold, that is runny nose, more than the runny nose, the sore throat, cough, fever, mild fever, then some pneumonia-like symptoms, then even myalgias, fatigue, tiredness, then headaches, excuse me, GIT symptoms. These can be looked at as COVID. So the short answer is, without doing the test, there is no way to say, but odds increase towards the COVID if you are living in the area of outbreak or if you have been in contact with COVID-19. So the way I see it, that every time I get some symptoms like that, I first suspect that maybe it is COVID and then other things. Then the second question is from Danielle here. Can you debunk the idea that vaccines for COVID will change your DNA structure? So I have done this discussion before. I'm going to do this talk once more over here. And that is, look, the vaccines are most of the time, so let's say we have two basic kinds of vaccines. One kind of vaccine is that we take some broken, disabled virus. For example, adenovirus is very common to be used. And in that virus, we put the RNA for the spike protein of the coronavirus. Then we inject this virus in a person or person's cells. So now, look, here is a very simple way to think about it. If the coronavirus arrives in our body, the actual virus comes into our body and replicates into our cells, it usually does not affect our DNA. This is not that kind of a virus. So when we give a vaccine, and that has the messenger RNA of the virus spike protein only, this RNA cannot go into the nucleus and do anything to the nucleus. And just to expand on that idea a little more so we can be clear how the DNA and RNA are separated, look, normally what happens is This is a cell, and here is the nucleus. Inside the nucleus is genetic material. So if I just make one part of the DNA over here, normally when some function is to be done by the cell. So let's say cell wants to make some protein. What it will do is it will open up the gene that is responsible, that has the genetic material to make that protein. It will copy that gene in the form of a messenger RNA, send that messenger RNA out in the cytoplasm. Over there, that messenger RNA will be taken up by the ribosomes, and those ribosomes will use that template and make proteins. So messenger RNAs actually do not go into the DNA or the nucleus. Then messenger RNAs do not do anything with the nucleus. Their behavior is to come out of the nucleus. So if we have the viral spike protein messenger RNA here, it is going to produce proteins. That is all it is going to do. So when the actual coronavirus does not modify our DNA, then how do we feel that a part of that would modify the DNA or not? So no, it will not modify the DNA. And I'm looking over there, if possible, we may have Luffy. I had promised folks that I'll have Luffy with us today. And I had been trying to catch him for a long time before the lecture, and he just keeps running away. So if my wife is able to catch him, then we'll see him. All right. So I hope that this question is answered. To modify the DNA, we need lots of enzymes, and we need very special machinery that has to go into the DNA and then splice out pieces of the DNA and then insert new one over there. And yes, there are some viruses that can do that. Coronavirus genetic material is not that way. Especially its genetic material for the spike protein is not at all that way. So vaccines are not going to do it. So if I take a vaccine needle over here, and it injects, let's say, directly the messenger RNA into the cell, that messenger RNA is going to go to the ribosome, make proteins, which will make spike proteins. Those spike proteins will then be presented on the cell surface as the enemy proteins, and then the remaining immune system would react. This has nothing to do with the DNA. So I hope that clarifies that question. Then there is another question which there's a second idea going around, that the cells are taken from live baby, harvested from their kidney while alive, then killed. I'm not making this up. So I need to know a little more, Danielle, about this one, that what cells, what kidneys. It seems very unlikely to me that babies will be used to harvest their cells and then killed. So I hope that these kind of things are not happening. I know there is a lot of evil in the world as well, but I have not heard of this. So Danielle, I would need a little more information about this. Then Moralong says CBD versus the dexamethasone. So CBD is something that I cannot talk about. So I will ask our lawyers if we can talk about CBD here. But good question. I'll have to first figure out if I can talk about CBD here. All right, then DRU, Drew. So some questions here. Quercetin update. So quercetin update is, look, this has been a very long discussion nowadays that maybe quercetin by itself is sufficient. There has been discussions that quercetin can cause the viral envelope to be destroyed. I have not seen those studies yet. My knowledge is that quercetin allows the zinc to go into the cell. Now hydroxychloroquine can act as a quercetin or the zinc ionophore, and if that is not available, we can take the quercetins as well, which are present in, for example, onions, red apples, berries, grapes, and some other foods. I've done many talks about this. So quercetin itself, maybe with zinc, is useful if hydroxychloroquine is not there. Problem is to understand that what are the dosage of quercetin, let's say, in one apple. And somebody had sent me a link where they said that here is a site that says in which food how much quercetin is available. So I think that would be a very interesting site to look at. Russian vaccine. So I have not studied up more about the Russian vaccine. I wanted to observe this a little more when they started using it. So Drew, I would actually look it up, and maybe next week we'll talk about it. Are we rushing vaccines? We do have efficacious treatment, unknown side effects. That is correct. we are going fast with the vaccines. And the problem we are trying to solve is, how do we make people immune to this virus? And there are two ways to become immune. Either the actual infection hits us and we become immune, or we get the vaccine. So still, I would say this as well. We have been going fast. But if you think about it, the whole world is focused on trying to figure out a solution. So even when we are going fast, the whole world's resources are available and focused on testing and trialing and figuring it out. There is lots of scrutiny, there is a lot of focus, there is a lot of attention to this. So in my opinion, even if we are going fast, the risk of really bad outcome is less. I don't think that we'll be given a vaccine without proper trial. Yes, there is one caveat to this, and that is sometimes vaccines are used over years and observed, the reactions observed over years. And we don't have that kind of data. That can only be available when the vaccines are used over years, and that's not happening. So that part is missing. But people ask me very commonly, would you take the vaccine? Yes, I'll take the vaccine. And someone had, so then people become very upset as well. But yes, if vaccine is to be taken, look, if I can be exposed to coronavirus, which is the actual real deal, and we are all ready, it can hit us anytime, then a vaccine is really a broken part of it. So yes, there are negative effects of the vaccine as well. Hopefully these will be looked at during the trials. Remember, in the trial, we look at the dose, efficacy of the vaccine or the drug, safety of it, and then the function of it. So hopefully, if a vaccine has been trialed correctly, I will be fine with it. Then revisit herd immunity. So look, herd immunity is the immunity. This is a statistical number, and that is that R naught is the spread of a virus. And that is from one person to how many people does it go to. That is the R naught. The R naught of the SARS-CoV-2 is about 2.5 to 3. So we have Luffy here as well, our guest of honor today, if he does. So here is Luffy. Luffy, come on, dude. So here is Luffy. This is the little guy who makes such loud sounds. Can you imagine? He's so little and he makes such loud sounds. Luffy, why do you shout so loudly all the time? So he's so cute. Kyrie is over there, but Kyrie is very difficult to get hold. See, she's now calling out. She usually doesn't come close to me at all, but Luffy is someone who can tolerate me better. Luffy, how are you doing?
In the second tab.
Okay, so I'm gonna put Luffy down. And here is Kyrie. Ow! So Kyrie is a little bit, Kyrie is always that way. All right. So these are Luffy and Kyrie. Going back to our discussions. So R naught, the concept of R naught is that from one person, how many people get sick or infected. The R naught for the SARS-CoV-2 is 2.5 to 3. If R naught is 1, that means that from one person, another person can become sick, and that's it. On average, just one person. And we say that disease is stable, it is not growing. If R naught is lesser than 1, then we say that the disease is slowing down and finishing. If R naught is greater than 1, that means disease is growing or spreading. Now, herd immunity is the statistical concept, and that is R naught minus 1 divided by R naught is the percentage of the people who should become, or who, when become immune to that virus, then the remaining percentage of people will statistically not be at risk. So if we take 3 for the SARS-CoV-2, I'm putting 3 just for ease of my calculation here. It can be 2.5 as well. 3 minus 1 divided by 3 is 2 by 3. So 2/3 of the population, when they become immune to the virus, then the remaining 1/3 has less risk of catching the infection. and possibly the R naught goes down to 1. So that is the basic concept of herd immunity. About 66% to 70% of the people, when they can become immune to it, then the remaining 30% will not have the risk. You have a huge initial knowledge, and now ACQ, ivermectin, early steroid feedback to create DrMobeen prophylaxis. Absolutely. So we can look at the protocol. I would rather take Math Plus protocol and in the initial part strengthen the prophylactic area and the initial treatment area. So we'll do that. And of course, your book. So there has been a friend from, I think he's in Africa, Karanveer Singh. He has reached out and he said, I can help. There are a couple of other folks who have reached out and said, we can help. My limitation is that I did not find enough time to be able to orchestrate the project itself. So I am actually looking for someone who can volunteer and say, I will look at the team and I will manage them to start putting the book together. So if anybody who can be a project manager, who can take some of the tasks and make them with me, and then have the team members that volunteer and work with them, then the book can come together. Otherwise, I am at a loss. The other possibility was for me to set up a website and then start writing every day a lecture that is done, just do a little article there as well, and slowly that would start building up in the form of a book. But for that, I have to set up a site and I have to pay the people who would set the site, and so all that is needed. And if somebody can volunteer with me, that would be awesome as well in that area too. If you're an engineer or if you're someone who want to put funds towards it, we can do that together as well. So that is the Drew. And continuing on, this is an interesting topic already. So here is what is this topic? Let's look at it. So I think here is it. Dear, I want feedback. PA 7.35 or above is related with good recovery. Deteriorates below this. I want case-to-case feedback, please. So interesting topic. Look, there are two ways to look at the pH. One is the pH outside of the cells, and then the pH inside of the cell. So let's say these are the cells. The spaces between the cells, the interstitial spaces, and the blood system or the fluid system, there is pH there as well. And then we are talking about the intracellular pH too. So this, I believe, question is related to hydroxychloroquine as well. So we are talking about intracellular pH. When that is increased, that means when the environment becomes alkaline, then the machinery of the cell reduces working. And that is a function of the hydroxychloroquine, one of the functions, and that causes the virus not to replicate. And remember, this is how hydroxychloroquine works with the plasmid as well, the malaria parasite too, because it goes in there and it goes into its endosome, the stomachs, and it kind of makes them alkaline. And our stomachs need acidity to digest the food. So when the parasite stomach is not acidic anymore, it cannot digest the food and it dies because of the food filling in its stomach but not getting digested. That is the same thing that happens inside the cells as well. But at the same time, many people respond to me and say, well, doesn't that mean that the cell itself will not function? And that is correct. If you give too much hydroxychloroquine, why do people get trouble? Why do they die? Because then their own cells would not work correctly as well. Therapeutic doses of drugs, everything is a poison when given in excess of the normal therapeutic dose. So therapeutic doses of drugs are measured in a way that they have least effect on our bodies. They still have side effects, but have more effects towards the function they are trying to do. So hydroxychloroquine in therapeutic doses, when given, would only make the environment sufficiently alkaline inside the cell to kind of stall the virus. And I have talked about it many, many times. My videos have been removed by Facebook as well. But there are 4 or 5 functions of hydroxychloroquine. Majority of those occur in the alkaline environment inside the cell. Okay, so the next question is Jason Barr. Are there other zinc ionophores beside hydroxychloroquine? Yes. So quercetin, since that looks to be hard to get, quercetin by itself, yes. So quercetin by itself, as I just discussed, can be a zinc ionophore. And the question only to answer is how much of foods or quercetin to take that can be decent zinc ionophore. I cannot answer that because there are no studies. So for me to sit here and say this is the right amount of quercetin, that is where I'm at a loss. So I would say take the normal label dosage with zinc, and hopefully that works. Rajul says there are many different views going on about amount of hydroxychloroquine as prophylaxis. What are your views? So very good question. And as the disclaimer you can see here, this is not a prescription, and please consult your doctor before taking any medication. So over here as well, the whole discussion here, this is not a prescription for any single person. Please don't get yourself in trouble. Don't make yourself a chemical lab. Don't get me in trouble as well. Be kind to yourself and to others. These are educational and informational discussions, and please use them as such. Now, hydroxychloroquine prophylactic dosage, I would look at a couple of things. The dosage that India has done is that they give, so let's say for essential workers, what they've done is week 1, 2, 3, 4, 5, 6, first week, 1 day, 800 milligram. And I think they give it in 400 milligram divided doses. And that's it, nothing else for the rest of the days. Then next week, 1 day, again, 400 now, divided into 200 and 200. And then for 6 weeks, they continue that way. So that is one way the prophylactic dosage is given. The only difference from essential workers to the people who are taking care of COVID-19 patients is the number of weeks. I believe they give essential workers 6 to 8 weeks, and the family members who are taking care of COVID-19, 3 weeks. Then if you look at Zelenko protocol, he gives 400 milligram in 200 milligram divided doses, morning and evening, for 1 week. And then he gives once a week, 400 milligram, I believe. So first 400 milligram for 5 days, and then 400 milligram once a week. I believe that is the Zelenko protocol. You can actually look it up on his site if I'm telling wrong. You can see it over there. My own work has been 400 milligram in 2 divided doses, morning and evening, and that's it, once a week for 3, 4, 5 weeks. But I am very, very careful. I do not take a chance on just giving the drug. What I do is I give 200 milligram and I take the heart rate and blood pressure before. I would really love to have an EKG available before as well. So once I give the 200 milligram, then I ask the patient to monitor their heart rate and blood pressure for the whole day. And if they're fine, then I give them another 200 milligram at night, and I ask them once again to continue to monitor. If they are okay, then I start the next dose. Otherwise, as soon as I see their heart rate has gone fast or slow, or blood pressure has started fluctuating, I stop it. So that is the about the hydroxychloroquine. Then, do you think politics and red tape is hurting the chances? So this is Luke Henry, chances of finding treatment and such for COVID-19. I believe so. So we had Dr. Yo with us, and I thought that he was tiny bit politically correct as well, and that is correct thing to do. But I do believe that because of the red tape, because of the socioeconomic factors, political factors, we have started to not focus on the things that are promising. And that may be because this is a new virus. Now I'm becoming politically correct. That may be because it's a new virus and there are new things that we have to figure out, or that may be otherwise as well. My opinion is for the healthcare folks, including WHO and CDCs and FDAs and other health institutes, look at ivermectin, hydroxychloroquine, vitamin D, vitamin C, N-acetylcysteine, quercetin, zinc, and then with that, see that steroids, early use, late use, is sufficient or not. I think that the treatment is this simple. Then, Kevin, do you think that Dr. Bruce Patterson-Ranty's CCL5 test kit for INCL will help doctors objectively quantify COVID-19 injury levels in hospitals? I definitely believe so. So anything that can tell us what is the CCL5 or CCR5 levels or Rante's level in the patient's body can actually tell us how much is the patient prone towards the cytokine storm. And as soon as you see that they are moving towards, let's say, arbitrarily from here to here, and this is going to be dangerous, as we see with studies, for example, then you immediately start steroids or other, for example, leronlimab or other drugs. So yes. So there is this one. I used to study French at some point. All I can speak French is vous êtes parlez français, and that's it. So Dr. Venkatesh Jawalgekar, how much is the prevalence rate in the age group below 5? And if it is low, what are the reasons? So we have talked about this a few days ago as well. Should kids go to school or not? Children have 3 or 4 things going for them. One of that is that they may, under age 10, they have less ACE2 receptors in their oropharyngeal area, so the virus has less places to bind. So that is one. Secondly, children have more natural killer cells compared to adults, and natural killer cells are the first responders, and so they can take care of the virus quickly. Thirdly, children have better trained immunity. Their innate immune system is much more trained, and because of the more frequent infections, respiratory infections they have, to be able to take care of the problem very fast. And then similarly, children have more trained or cross-reacting immunity as well. For example, their macrophages and dendritic cells know more of other coronaviruses as well because of frequent infections, and they can very quickly cross-react with the spike proteins of this coronavirus. Or similarly, flu virus in them can give them cross-reactivity for coronavirus. So they are better prepared than us. Interestingly, children below the age of 1 are at a higher risk as well. So it is really 1 to 10 that are lower risk. 10 and above, the risk starts increasing. What are the radiological findings after 2-3 months of the patient with pneumonia? So radiological findings, as we know, are the first is the infiltrates. Infiltrates are the lungs start becoming opaque in the basal area first, and then the curly B lines start appearing. And then if the disease progresses, then those opacities start appearing in the rest of the lung as well. If they resolve, then the opacities go away. And if the fibrosis occur, then the fibrosis findings would appear and so on, which may be more easy to find in CT. Does the lesion recover or any residual damage? So very good question. Lungs are very resilient. Normally after the pneumonias, lungs recover. But in case of COVID-19, sometimes the damage is big enough, large enough that the baby lung physiology occurs, so the lung become fibrosed and scarred and small, and getting them back to normal is almost impossible. So it depends what is the intensity of the damage to the lungs, how far the immune system caused the damage and scarring and fibrosis, and that is what would determine that is there residual damage or not. There are people who have recovered and now are going to be on oxygen forever. So that is because their lungs have gotten very, very damaged. I also know patients who are on ventilators. Now they have come out of coma and they are still not able to breathe properly because their lungs have a lot of damage. So they have to stay in rehabilitation for a long time and then probably on oxygenation for a long time. And some patients actually need lung transplants. So it depends. Then we want to know the mechanism efficacy of, so we'll talk about the drugs, the newer drugs next week, so I can discuss these in detail, Rajul. COVIDUS.org says, for Friday open discussion, if COVID-19 is seasonal, what will be the increase from July 2 million to January, February, the height of seasonal virus cases? This is from a Japanese study of cold type coronavirus on monthly basis. So we are still not clear that how seasonal is this virus. We haven't gone through all the seasons with it. We haven't gone through multiple seasons with it. So there is a study, or there are multiple studies now that show that in the warmer weathers, the virus spreads less but continues to spread. So don't know how exactly in the cold weather, although in New York we saw that was cold time, that it spread very fast. In the same coin, in other cold areas, it did not spread that fast. So I think it depends upon people's behavior as well. The seasonality seems to be there, but it is not that it would go away and come back in cold. It seems to be fluctuating with the season, up and down, but not going away at all. The interesting thing to see, and as the cold season comes around, will be that with other cold-like symptoms and viruses, what will happen when this is combined with them? That will be something to look at. What are your cat's favorite toys, and can they come to say hi? So yes, so they both have come to say hi, or one of them, Kyrie, just protested and ran away. The toys, so one of the toy that they have, which actually is my favorite as well. So that toy looks like this. So there is a plate like this, and in this plate there is a little ball which is in it. It cannot come out. So they both sit on the sides of it, and they this is the cat. And they with their paws, they hit the ball, and the ball rotates, and they look at it, and when it stops they hit it again. So that is their favorite toy. They also like those little mice. They are all over here, that they like to play with those mice as well. What is that, cloth mice. Okay, so I and my wife took antibody test. My immunoglobulin value was 0.6, while my wife was 0.06. We took the test for accidental exposure, didn't have any symptoms. Does the difference in value mean anything? Below 1.4 was the test said it was negative. So not really. So if below 1.4 was negative, that means test sensitivity and specificity below that is not really reliable. So as long as it was below that, you're fine. Doesn't matter if it was more or less. That would depend. You have other coronaviruses, you have cross reactivity. If the test is reacting with other antibodies present for other antigens, so no worries. And everybody is different. Robin says, how should people with lingering symptoms be treated, specifically lingering migraines? So I have seen in all cases of long haulers. So it is less studied area. The question is it the virus that is still lingering and have they become carriers? Or is it the immune system that has become dysregulated and is going to become chronic? Either way, in my own patients, what I saw was that giving delta cotril or the steroid, low dose steroid for a few days clears out those symptoms. Dr. Paul Marek, when he was talking with me, he said that he said that statins can be useful as well because they are anti-inflammatory. So I think there is no one real answer. It is everybody has a different, every doctor has a different experience with it. Some doctors I've seen do not have a clear idea of what to do. Some doctors have done some experiments. My experiments are that low dose, low intensity, short term steroids can be useful, but also please remember steroid can be very, very dangerous as well. So please don't take them by yourself. Talk with your doctor. Eric Mag says, what are your thoughts on leronlimab now that the safety board is moving forward with the trial and odds you think it will be halted in the interim? I don't know. So the data that I've been trying to find for leronlimab is the efficacy data, I believe. So safety data has been there. Efficacy data I have yet to see, and that may be my ignorance that I didn't find any paper or data yet. So once I look at that, I can talk more about it. Before that, I'm just, I don't know. Murat Sai says, what is your opinion on low pH nasal gels for prophylaxis? These are some papers on the positive effects of those gels on rhinoviruses. Can they also decrease viral load at first sight? So here is how I will think about it, because we don't have any studies about it. This is all a matter of opinion now, and my opinion may be totally incorrect. And that is that, so let's say this is the nasal area, right? So, and then here, This is the mouth. So let's say in the nasal area, these are the cells here, and these cells are epithelial cells, and the environment between them becomes alkaline. Question is that if the coronavirus comes in here in the alkaline extracellular environment, will that do anything to the virus? This is what I do not know. I know that if the environment inside the cell is alkaline, then virus will have difficulty entering and replicating. But what I don't know is that if the alkaline environment is available outside, would that hinder the virus a lot or not? The reason alkaline system could cause any issues is that so let's say this is the fluids in the nose, and they have less pH, high pH, meaning they are alkaline, or the environment is alkaline. Alkaline means the hydrogen ions are less and bicarbs are more. So now, let's say if we put a virus here, so I'm just doing medical thinking with you. I do not know the answer. I haven't seen the studies. So if we put the virus over here and bicarb is in greater concentrations, if it starts going into the cell, or if it's the virus, or it starts pulling things out of the cell because of concentration or fluids going in or out, that might change the virus's structure or might damage it. But once again, I do not know the right answer to this one. So then, zinc with ionophore, the unmentionable hydroxychloroquine, quercetin, EGCG, and so this is the, I believe somebody has put some protocol out there. 3-ply mask. Article in Nature suggests that hydroxychloroquine is not by itself effective in inhibiting SARS-CoV-2 viral entry in human lung cells. This may partially explain why clinical trials of HCQ have reportedly. So I'll have to look into this. Over here it says chloroquine or hydroxy. I'll look into it. So these are the questions that were on Twitter. There are some questions that are on YouTube as well. I'll just look at a few of them, and then I'm going to go to our discussion that is happening right now live over here. So some questions there on YouTube. Which steroid is good, Dexa or methylprednisolone? So from according to Dr. Paul Marik, methylprednisolone is better because it has better coverage of the lung tissue, but they both are systemic, they both are useful. Dexa is more potent than methylprednisolone. So they both can work. Dexa is fine as well. Dexa has shown efficacy, so taking Dexa is not a problem. Then the next question is open for, what are your thoughts about the mysterious skin manifestations of COVID-19? So the skin manifestation, the question is it galectin-3? So far, what I know about the skin manifestations is the hypercoagulability causing the blood vessels to become inflamed, number one, and number two, the blood vessels to become occluded because of the thrombi that are going, and that is causing the skin manifestations. There may be more. Tomorrow's open forum. India government has asked to wear masks without valves. Is it logical? So there are masks that have valves in them, and those valves allow the air to move easily. I think it is okay because they are tested, but if the government has said it, they must have a reason. Then there's a question about favipiravir. So favipiravir is being used and in trials, so we'll see when the results come out, but at least from a mechanism point of view, it seems promising. So there is a question that on YouTube that the Math Plus protocol, Dr. Paul Marik and his hospital claims that the fatality rate after using Math Plus protocol is 6% compared to 20 or more percent in other hospitals. So he's saying that, do you believe in this claim? So I have not seen the data itself. This is the claim from the hospital. So I'm sure that it is based on data. I hope that they're not telling incorrect messages there. I said I was going to say that I'm sure that they're not saying incorrectly, and then all of a sudden I was reminded of the Surgisphere, where they had created a whole study which was incorrect. So I hope that the hospital is reporting correctly, and if that is the case, then we should believe it. I have talked with Dr. Paul Marek. I really respect him. I don't think that he would lie to us or he would tell incorrectly, but without seeing the data, I can't vouch for it. I can vouch for Dr. Paul Marek. Okay, so this is the questions that were there. Now let's look at the questions here. If you had a question before, please do me a favor, write the question, word question, and then the question, so I can sift through the comments, and I'm going to look at some of the comments here and see if I can answer them. How are you doing so far? So we are 41 minutes into it. Are you okay continuing for some more minutes? My biggest criticism from the folks who watch us is the length of the videos. Somebody had put a comment on YouTube saying, give us summary. Nobody has time to watch your long videos. So I think that sometimes content is important for us. So here there's a question. Is a blood type still showing to contribute to more severe symptoms? Sylvia, I haven't seen more studies about that. So that is just one study that we saw before. I haven't yet seen more studies about it. So there's a question from Tony. Dr. Bean, what do you think about Epics? So let's talk about these 2-3 drugs next week. I would do some studies as well. I'll draw some mechanisms too, and we'll talk about them. There was a question. If N-acetylcysteine, so James says, is a precursor to glutathione, why not just use liposomal glutathione? Very good question. And if you watch my video about the N-acetylcysteine, N-acetylcysteine has 2 mechanisms. One is to help make glutathione, and the second one is it itself is a very good antioxidant, plus it helps in breaking the sulfur bonds. So its own mechanism is very, very useful, in addition to helping make glutathione, which in turn is also going to break the sulfur bonds plus is antioxidant. So James says, keep the whole video. Will do. So a few days ago, because of these complaints, what I had done was I chopped off the last part of the video where we had these question and answers. And one of the cool beans sent me a message saying, when I went to sleep, this was 41 or 50 minutes. And now I woke up and it is 33 minutes. What happened to the video? So I had edited the part of it out to make it short. So there's a comment here, Gamer1. We would like to hear from Dr. Meena on the proposal on using antigens. So I will, to stop the rapid spread of the COVID human challenge trials. So I would actually talk about Dr. Meena and his discussion as well. I have heard about it. I have not gone and done a deeper study, so I'll look into it. Guru Gill, how much time do you spend on research and preparation of content, and does someone in your team do it for you? So good question. So candid and honest answer. I start in the morning about 12 o'clock and I study till 6 o'clock. I go over, it's not just that I study, I actually have to, my habit is I have to highlight while I study to understand. I cannot remember things if I do not highlight them or underline them. So I have to pick up the books and look at what the text says and then look at the studies. So that research is all done by me. There is, I'm taking a risk saying this, there is a outcome of this that my engagement here has caused less attention to the business, and my business has suffered a lot. So I am still happy and proud of doing this because we are all, at this time, we are in an exceptional time. We have to do this. So people have to rise up and do the right thing. So I'm doing it. And I am very grateful to support of many of you who have donated in various ways or have said that you can help me with the research. But Guru, the shorter answer is that I do the research by myself. Okay, so there's a comment here from James Kelly. Dr. Joseph Varun in Texas has a 95% survival rate despite treating a high number of Hispanic and poor people of color. He too used Math Plus, and this alone will verify. Absolutely. I am a fan of Math Plus. Wherever I go, I ask my friends, I ask the ICU friends who are working there to use Math Plus. Math Plus makes sense. If I can once again take this risk of saying that in the early part of the Math Plus, I believe in addition to antivirals, steroids have a benefit. May that be budesonide, like Dr. Bartlett is doing, or oral, but there is a use of steroid. The thing is that has to be done under observation, so so that we do not risk somebody. So, but I think that the whole strip of the disease, the whole stages, spectrum of the disease can be managed with steroids too. Great. Thank you very much, Guru. What's the plus? So in the Math Plus, so that is the 4 basic drugs. I think methylprednisolone, ascorbic acid, what does thiamine and heparin, plus other things, for example, enoxaparin or other drugs that may be given. Thoughts on ARB for now new onset hypertension due to the RAS system dysregulation? So yes, ARBs are very good. So as long as the contraindications or as long as the side effects are not bad, they are very, very good actually. You're very welcome. So Guru says, I asked my wife, I asked this because my wife is always angry at me to spend so much time on learning. When I got married, the very first night, the only thing I said to my wife was, please never object about my reading or my working on computers. So I'm a software engineer as well. So I love software engineering. There are some books here too, and I program. So I said, please don't ever stop me from these two. And she's kind enough that she has upheld that promise. Question. I'm trying to see for question. Does colostrum have any benefits? I haven't heard of the benefits on the colostrum. Look, so colostrum is what it contains is the antibodies from the mother. And so if those antibodies have good antibodies in them, then of course that can be useful. But if not, then not. So, but I have not seen colostrum directly being useful for COVID-19. So this question, M. Gregory, will COVID get worse from autumn and winter? There have been countries that have gone through winters while COVID was happening, and I have not seen worse. Some people give me examples from New York. I think that political and management and other factors may have been there. Cold seems to have, the virus seems to be more spreading in cold compared to warm temperatures, but I haven't seen huge difference in cold and warm. Debbie says, does your wife mind your drawing cartoons? Not at all. She actually loves them. She herself is studying animation. So she is playing with cartoons all the time. So she takes those little 3D characters and then she, makes a move and jump. And whenever I go to her office, I say that, hey, show me what your latest character is doing. So we both do these kind of things. So there's a question, Kurt says, is the passage through the blood-brain barrier and neurological deficit we're seeing more likely higher inflammation or a code in the RNA since we see more with this coronavirus over others? This is because of the inflammation, because of the hypercoagulability states, and because of the presence of galactins in the brain, plus presence of the ACE2 receptors in the brain as well. So multiple factors that are causing this. Ambal says, if the published protocols, I could choose the hospital to go to. So I hope, correct, you're right. I think most of the hospitals have their protocols published, but I don't think all of them. Have you used inhaled steroids in your patients? Not in the early stage. In the long hauler stages, yes. Or during the shortness of breath, not in the early stages. In the later stages, yes. Regarding miscellaneous C, do you think it's actually related to coronavirus, or could the outbreak have been coincidental? It may have been coincidental. I did not look deeply into it, but I was not convinced that this is related. So thank you. I believe every hospital should be required to publish. I agree with this, Embal, that every hospital should publish their treatment protocol. Although I would say this as well, that I would not want us public to hold a hospital to say you should have one, you publish the protocol and then you should only work with that protocol. Doctors should be allowed to think. Just like a few minutes ago, I was thinking about alkaline environment in the nose and can that do anything to the virus or not. So I did not know the answer, but I was doing medical thinking. So doctors should be allowed to do that as well. So the only risk of publishing the protocols is people would say you didn't do this protocol exactly, so now you are liable, while they had done some good thinking and should be given that chance as a doctor. You're very welcome. So there's a question. Galectin-3 is highly upregulated in COVID-19 patients and plays a role in many of the hallmark pathologies. Do you think an inhibitor would be a good option to manage severe cases? So again, I did the discussion yesterday. From a mechanism point of view, it looks very, very interesting because compared to other drugs that take care of one part in the immune system, for example, they are either blocking IL-6 or tumor necrosis factor or GM-CSF, or the ACE2 binding, this one galectin inhibitor seems to, number one, reduce the ACE2 binding of the virus, plus reduce the IL-1, plus reduce the IL-6, plus reduce the tumor necrosis factor alpha. So it does more than just one thing. So to me, from a mechanism point of view, it seems interesting. We are going to get in trouble with WHO not following the script and acting like a doctor. Correct. So I'm going to talk about WHO tomorrow because I've become so sick of this that people keep, my own videos are removed. Today I was seeing 4 videos are removed now. Facebook blocked one of my posts, which was totally, you have seen that I do not pass rumors here. I do not propagate rumors. I do not do tin hat discussions here. I talk about mechanisms and I look at those mechanisms, then I bring the studies out, I give the references to the study, I show the studies when I teach. So it is a mainstream discussion, medical discussion. But in the name of WHO, we've been punished so much sometimes that it is important to look at the leader itself in his name or their name, others are being punished. We should look at that leader and see what the heck are they been doing. So I'm going to talk about WHO tomorrow. After recovery, do you think 1 time a week Plaquenil would be smart? So there is a question as well on the YouTube side, which I forgot to mention, and that was the reinfection. And somebody had said that it seems like reinfection is possible. This question is in a similar vein, that maybe the virus can come in again. So look, let me give you the answer to this one, which is very simple. And this is a medical answer. Evidence would tell us that can the people become carriers or not? Carrier is a medically known fact as well, that the virus can just stick in the body forever. Hepatitis has carriers, right? So the thing is this, when the virus arrives in our body and our immune system responds to it, takes care of it, kills it, reduces it to the point that we recover, that means our immune system has the ability to manage that virus now. So if it can come into our body once again, we can manage it, number one. Number two, now we have memory cells as well. So our immune system is actually going to respond faster and with better precision and accuracy. So our immune system is now sufficient to take care of the virus once we were infected and recovered. We don't have to take drugs. Although vitamin Ds and vitamin Cs and quercetins and zincs and N-acetylcysteine, these things should just generally be taken as long as they're not contraindicated to you, because they keep your immune system balanced. So that is important. And I want to clarify one concept over here that many folks talk about, and I'm going to share my screen for a second. And that is the antibodies. We saw that study and we said that, hey, after 3 months, the antibodies started going down, correct? This was the discussion. I think what we missed, and in my discussion I talked about it, but still media does not talk about it. There are two types of antibodies. One is the binding antibody. Binding antibody, as I've been saying, they can bind anywhere on the virus without disrupting its function. And the other one are neutralizing antibodies, which when attached to the virus, they would disrupt its function. For example, they would attach with these spike proteins. The study that showed the results that the antibodies were perishing and declining, that means that the memory cell that are making them were declining or making less of them. They showed that the binding antibodies declined by 8%. And I would put the word only, 8% only after 3 months. So from 100, the antibodies became 92. And then another 8% decline, let's expect, in another 3 months. So what would that be? Maybe about 7. So it would go down to, let's say, 85. Then another 3 months later, it would decline, let's say, another 8%. And then let's say we'll go to 79%, and so on. So this is not a very rapid decline. It's a slow decline for neutralizing antibodies. So if it is 3 months here, 3 months here, 3 months here, we still are at 79%. Maybe another 3 months, and what would that be? Another 8% decline to this one is, let's say, 64%. That is not a bad, although my graph is showing a very big decline here, but 64% is not a big decline. What we do not know is that how much percentage of the binding antibodies are needed. So let's say if 50% of the binding antibodies available after the fact are, if present, can handle, then that means 3 months, 3 months, 3 months, 3 months, another 3 months later. So maybe 1.5 years later, will go at risk. The antibodies that fell fast by 70% or more were the binding antibodies. We don't really care if the binding antibodies go away. So what? They don't do anything. It is the neutralizing antibodies that are needed. And in that study, they showed it that it was only 8% decline after 3 months. Somehow the media and the articles did not pick that one. I think they like to make people worried and nervous and scared. I am not scared with this kind of a decline. It's 8% on neutralizing antibody per 3 months. Not a big deal. Okay, so then there's James Kelly says, given the very high education requirements to become a doctor, maybe experience that all doctors should be allowed to freely express their views and opinions. Absolutely. After all, free speech. Yeah, James, the interesting thing for me is that the person who looks at a post and says, I think it is wrong, what is their own qualification? Are they qualified to say this is right or wrong? Okay, so then here there is a yes about 1.5 years. So I think to sum up my answer, you don't have to take hydroxychloroquine afterwards. I think your body is actually much better now suited to manage that virus if it arrives in the body again. So there's a question from Zoltan. Dr. Mubin, why ivermectin is not so widely used in the world and covered by the media? People even docs don't believe it, work until the mainstream media doesn't cover it. That is a correct thing. And I think ivermectin works. It's just that it is not hyped up that much. Hydroxychloroquine, on the other hand, has been hyped up, but is also hyped up negatively too. So many people are actually afraid of using it. So ivermectin has been very, very interesting. Ivermectin plus doxycycline combination is very, very effective and safe as well. Please remember ivermectin, I say it every time, not in pregnancy, not in lactation, then not in the people with the blood-brain barrier issues. It can cause permanent damage, brain damage. So question, I have heard that the SAR antibodies have been present 17 years later. Have you seen or heard this? So SARS-CoV-1 antibodies, the studies that I saw was that the antibodies stayed on for 3 years. They started declining significantly by 2 years. So I would expect that they were declining just like we're seeing here. They were declining slowly, and 2 years later, their numbers were down, but they stayed on for 3 years. I haven't heard 17 years. Morris, if you can be kind enough and send me a link. So Muhammad says, can you, what was the question here? Can you shed the light on the mechanism of antidepressants? So Muhammad, I'll take that up. So these new things that need a little higher level of understanding, we will do them as an independent drug next week. Can we say that the COVID-19 is manageable acute inflammation viral disease? So Rishi says, can we say that COVID-19 is manageable acute inflammatory viral disease? So I would say it this way, and I think this is kind of clear. To me, there are 4 phases of the disease. Asymptomatic, we don't even know what's happening there. Viral stage, where virus is now replicating and causing symptoms. Then the immune system stage, where immune system has become dysregulated. And then the carrier stage, I shouldn't call it carrier, long hauler stage or phase, which may be because of the immune system dysregulation, or because of the viral, or because of a combination of both of those, or because of the tissue damage that has occurred, which is still healing. So it is manageable, yes. Immune system phase needs to be managed differently. The viral phase needs to be managed differently. Here is a catch though. I believe in the viral phase, steroids have a place. And here is why what I'm saying is can be wrong. And that is, if we suppress the immune system and the virus is replicating, we might allow the virus to become spread more, and it can cause more damage. That is why we all doctors are afraid of using steroids in the early part, because we might allow the virus to become spread faster. However, the doctors who have used steroids in the early part, they swear by it that it has been working. I had been talking with so many of my friends in Pakistan because I'm surprised how Pakistan's graph went down. Let me show you how it looks. And so I ask them all the time that, hey, what are you guys doing? And guess what are they doing? They're giving steroids. So look at this. This is Pakistan's number. So here is the data. So if you see, they were actually at this point, they were in a bad shape because the people were not taking care of the masks very well. They were not taking care of the physical distancing. The lockdown was not really very decent lockdown. So they were actually in a bad shape here. And it seemed like they're going to get in trouble, 220 million people's population. And then all of a sudden, it just started dropping. So I asked my friends, I said, what is going on over there? And they said that we use steroids. So I think doctors have learned to manage it outside in the other countries. So Zubair says that which steroid is better in COVID cases? So look, I love Dr. Bartlett's idea of the inhaled steroids in the early part, if to give, so that it doesn't have systemic effect. And I love the methylprednisolone or dexamethasone. Both are fine. If you look at Dr. Paul Marik, he says methylprednisolone is better than dexamethasone. So I would go with that. I love Dr. Paul Marik, and I love his work. Dexamethasone, Oxford study says it is fine as well, so that is fine too. So these are the 3 that I can say this. In long hauler stage, delta cotril seems to be a better answer. So once again, please, this is not a prescription. These are educational discussions. This is not targeted to any single person. Okay. So there's a question, shouldn't we have social media exclude doctors to share without censorship? I don't know, how would they confirm? Maybe they send me a note saying, hey, if you're a doctor, prove it to us. I saw Reddit, so I post my videos on Reddit as well. And Reddit, they did something very interesting. The mod of the Reddit where I post, he reached out to me and he said, we have watched many of your videos. We make sure that we watch the video before we let it be on our channel. And please do me a favor. From now on, put your name, Dr. Syed, with the title, and we will know it is from you and we trust you. So he didn't say it in all those words, but this is what he said. If you put Dr. Syed, we'll have we don't have to go and watch the video again. So I think some way of developing trust has to be there. But in the meantime, this is what it is, that they're just punishing whoever they think is said some keywords that trigger them. I was thinking about it yesterday. If medicine was starting, let's say 200-300 years ago, when the modern medicine was starting, and if the rules were like today, I don't think that modern medicine would have evolved the way it evolved now. So, or till now. I think if we apply today's rule 200-300 years ago, doctors will not be able to work very well. At the same time, I also know that, I forgot the doctor's name, who had said that to reduce the infections, we should wash hands more often. And we should not go from autopsies to directly delivering babies. And in that process, we transmit something that causes mother and baby to die. He did not know these are exactly infections, but he said washing hands is important. He was made fun of. He was put in a mental institute because people thought he's mental and so on. And I think he died there as well. So these kind of things happened before too. This should not happen in this modern enlightened world. So Deborah says that, would you be kind enough to provide the link to the site for the graph? So yes, so it's very, very simple. Deborah, if I share that site once more, this is John Hopkins. So I normally just go to Google and I say Johns Hopkins COVID-19 dashboard. And the very first link that arrives is this link. So here you can see it. And you can actually check it out if you see here. And guys, my apologies. It is 1 hour, 10 minutes. I know that people are not going to watch this video now, but I think there is useful information in here. So over here, you can see various countries and their graphs. And I really, really am grateful for your time, for the cool beans who are sticking with me, who are studying with me, who are sharing ideas with me. We have become, I think, we are the strongest community in terms of understanding of the COVID-19 on the web or in the world. I haven't seen such strong community in terms of understanding of the concepts. Cool. So, so ITJ Music says Worldometer has a Pakistan page that shows a successful fight against, yeah. So there's Kurt says, on a Zoom conference with Egypt, and they have limited their personnel and supplies in the patient room to break down the cycle of infection and are doing much better. Our hospitals have too much crowding. Yeah. In the US, we have more issues than just the management. It's the belief system. It's the hydroxy, not hydroxy, steroid, not steroid, and more expensive drugs versus less expensive drugs. So there is a lot that is happening. So the question is, and let me take a couple of more questions and then we stop. Omajin says, how does viral RNA affect the immune response when it enters the nucleus? So first answer, viral RNA does not go to the nucleus. The product of the viral RNA that are produced, some of that cargo can go to nucleus and cause the nucleus not to defend itself. And that is where ivermectin can come and help. And then it causes the nucleus not to release the interferons and interleukins that can tell the other things to come over. So there are some proteins from the virus that can go into the nucleus and whisper to the nucleus and say, don't do anything that would help you defend yourself. So that is how it affects it. But RNA itself does not go into the nucleus. RNA is not embedded in the nucleus and so on. So Debbie says that any specific antivirals being developed. So all those drugs that are going against the S proteins I would say that these are kind of antivirals that are being developed. Excuse me. But then the other categories of antivirals, like uncoating or RNA-dependent RNA polymerase disruptors and so on. So we have many such drugs. Favipiravir is that way. Zinc is that way. All right. So I think this is good enough. How about we talk about WHO tomorrow? And please forgive me if I have not answered everybody's questions. We can take more forums. If you like this structure, we can, for the whole week, we can collect the questions and then answer them once a week. So this is a question on the nasal lavage. So look, I actually am a believer of nasal lavage, mouth gargles with the salt water or Listerines or other such things that can keep the mouth clean. I am in favor of that. What I do not know is, can they be used as prophylaxis or as treatment? I do not know that. So ITJ says, once a week open discussion. Excellent. So what we'll do is this. Every week I'll tweet and I'll say, please put your questions, and we'll just put the questions below that tweet and I'll curate them at the end, and every Friday we'll talk about it. James says, Dr. You're so amazing. Human a doctor, scientist, amazing, talented teacher. Sending you much love and blessings. Thank you very much. And you stay safe and take care as well. So tomorrow we'll talk about WHO. We'll talk about what WHO has been up to. All right, guys. So Paul Elkin says, it's difficult to catch all the pearls of wisdom that Dr. Bean churns out. So sorry, but I hope that they are useful. So Chantal says, what are your views on these, Dr. Bean, being used in the prevention of COVID-19 being detected? I forgot the basic context of this, Chantal, the question's context. Excellent. So guys, promise me to stay safe and healthy. Keep taking your immune boosters or immune optimizers. Stay at a social distance. Have the masks available. Wash your hands. I think even my time is now more. So wash your hands. Please stay safe, stay healthy. And any support if you can provide, if you can help me write a book, if you can help me put the site together, if you want to donate in any ways, if you can just like, subscribe, and share, anything you can do, that would also be useful. I think we have developed a good community and we would continue doing this. So thank you very much. Bye-bye for today.